Meet Terry. Terry is a gentleman gaining in age and is presenting to clinic today complaining of pain in his epigastrum. He describes this as gnawing in quality. He states he's had minor discomfort occasionally in his stomach for years, but in the past 4 months, it's gotten much worse. He states that the pain is sometimes accompanied by nausea and emesis. He also reports feeling full more quickly while eating, and he just can't seem to eat enough to keep his weight up. He also reports a significant smoking history. He works for a catering company and reports eating lots of cured meat and cheeses, with an otherwise relatively balanced diet. Hmm, look at those lab values. Sure looks like iron deficiency anemia to me. We're asked what the likely diagnosis is and what would be the confirmatory test. In cases of unexplained iron deficiency anemia, a full workup is usually warranted. But in this case, Terry doesn't have an unexplained case with all his upper GI symptoms going on. I'll bet there's something going on with his stomach. Epigastric pain? Nausea and regurgitation? Slow bleeding? I'm guessing he's got an ulcer. Hey, wait a second. Peptic ulcers were covered in their own sketch. So, what could be going on with his stomach? We are going to start this discussion with a big old disclaimer. You may notice a large lack of discussion of peptic ulcers in this discussion. That's because it's such an important condition, we felt it deserved its very own sketch. Head on over to the PUD sketch if you haven't already had the chance. So let's get going with this sketch and see what we can find out to answer the clinical question about Terry. The differential for acute or chronic epigastric pain should always include gastritis and gastropathy, in addition to the usual culprits of PUD, GERD, pancreatitis, etc. And while many gastropathies and gastritis are similar in etiology and even treatment, they're all a little nuanced. But fear not, we'll go through it in a way you'll be able to stomach. Whatever, GI puns are hilarious. Anyways, both gastropathy and gastritis involve gastric epithelial damage and regeneration, but the key difference, not surprisingly, is inflammation. Acute gastropathy is the damage, destruction, and erosion of the gastric epithelium from a non inflammatory cause. Quick note here: if irritating substances damage the gastric mucosa enough to cause erosions, edema, or even hemorrhage, it's safe to assume there's some degree of inflammation going on. The distinction between opathies and itises refers more to the inciting agent and not necessarily a complete lack of inflammation in gastropathies. You most likely will hear the terms used interchangeably, but it's important to remember they're not the same thing. Acute gastropathy typically presents with epigastric pain, which can be severe, with or without nausea and vomiting. Sounds similar to our clinical case, Terry. And speaking of severe, acute erosive gastropathy can be bad enough to cause hemorrhagic upper GI bleeding, which requires quick diagnosis and treatment. This may present as melena as blood passes through the GI tract and becomes partially digested, turning black and tarry. We've represented this with the soy sauce spillage you see. But remember, if it's a brisk bleed, it can be hematochezia instead. Upper GI bleeds can be a difficult thing to manage, so we've made that its own sketch. Head on over to the upper GI bleed sketch for all the gut-wrenching deets. Remember from our clinical case that Terry had iron deficiency anemia, meaning he was bleeding from somewhere, but he didn't report any melena at all. Acute erosive gastropathy can be caused by damage to the surface epithelium. This may be due to direct chemical injury from ingestion of NSAIDs, alcohol, and iron supplements. Chemotherapy sometimes falls into this category too, although it's often multifactorial. Acute gastropathy can also occur as a result of decreased mucosal blood flow, leading to ischemia of the gastric epithelial cells. For example, cocaine causes acute vasoconstriction and decreased mucosal blood flow. Bam! Ischemic gastropathy. Thinking back to our clinical case, remember that Terry didn't have any of these risk factors we just talked about. Stress ulceration, also called stress, gastritis, is another type of gastropathy related to impaired mucosal blood flow, although the pathophysiology is a bit more complicated here. It involves increased bile reflux, impaired synthesis of the protective mucus layer, and in some cases, hypersecretion of acid from parietal cells. As much as we'd love to think that things like med school exams are some of the most stressful things you can imagine, the stress we're talking about here is much more physical in nature. Stress ulcers occur following major trauma, shock, sepsis, or serious illness, and are seen primarily in ICU patients. Think of stress ulceration as end organ injury of the stomach in a severely ill patient. When stress gastropathy results from a major burn, usually over 20 to 30% body surface area, it's called a Curling's ulcer. Hence the scalding hot, curly noodles. This is due to decreased perfusion of the mucosa due to resultant hypovolemia from insensible fluid losses. Man, those are extra curly. My favorite kind of noodly noodle. Stress related gastropathy can also occur after major head trauma. This is called a Cushing's ulcer. This ulcer results from hypervagal stimulation due to the trauma sustained by the CNS. No, not Cushing disease. Don't go there. We're not talking pituitaries here. Critically ill patients at high risk of developing stress ulcers and bleeding should be started on acid suppression at prophylactic dosage, either a PPI or H2 blocker. This includes patients who are on mechanical ventilation for over 48 hours, patients with a history of GI ulcers, severe head injuries or burns, as well as those with sepsis or a prolonged ICU stay. Well, this all doesn't really sound like Terry from our clinical case. His symptoms fit, but the etiologies of acute gastropathy don't really fit him at all. Let's move on to this old grandfather clock on the top shelf and chat about chronic gastropathy. Chronic gastropathy is technically called reactive gastropathy, as in a reaction to something irritating the stomach. Again, at the top of the list of causes is NSAID usage, but this time it's a little different. The gastric mucosa of most patients taking chronic NSAIDs adapts to prevent acute gastropathy or ulcer formation. This is how all reactive gastropathy develops. The stomach adapts to chronic exposure of some substance that can lead to injury to the mucosa, resulting in hyperplasia, edema, and smooth muscle proliferation. Reactive gastropathy can also be caused by chronic reflux of bile into the stomach. This may develop after GI surgery that alters the normal plumbing anatomy. For example, a gastrojejunostomy or removal of the pylorus. Bile salts are directly toxic to the gastric mucosa. Ouch! Other causes of reactive gastropathy are abdominal radiation and mesenteric ischemia. Alcohol is also thought to contribute. Again, doesn't really fit our clinical case from the beginning, but let's finish up talking about it just for kicks and giggles. Definitive diagnosis of acute or reactive gastropathy requires EGD, for both visualization of the mucosa, to look for erosions, edema, or hemorrhage, and biopsy. You may hear the term gastritis used to describe the appearance of the mucosa on endoscopic evaluation. However, the differentiation between gastropathy and gastritis requires tissue biopsy. EGD is most commonly performed for severe or prolonged symptoms and to rule out serious complications like bleeding. In any case, treatment of both acute and chronic gastropathy involves removing the offending agent, if possible, and acid suppression with PPIs or H2 blockers. Let's move on to the next condition. Acute gastritis, as in an inflammatory cause, is most commonly due to an infectious agent. And guess which one? Yup, herpes. Nah, it's H. pylori. Remember, at Sketchy, a helicopter represents H. pylori. But we couldn't squeeze one in on this sketch. So we have these helicopter-esque fan blades. While H. pylori is the most common cause, other viral, fungal, and even parasitic infections can cause acute gastritis as well. There's a lot of people who look all vomity in this sketch. Have these stands had health inspections? I want to see some inspection grades, and they'd better be A's. Acute gastritis due to H. pylori may be asymptomatic, or it may present with epigastric pain, nausea, and or vomiting. Aha! Sound familiar? Remember, Terry from our clinical case had all of these symptoms. Given the prevalence of H. pylori infection, which is greater than 50% of all people, and the fact that relatively few people go to the hospital for acute gastritis, most people are probably asymptomatic at the time of initial infection. Other infectious agents may cause more severe symptoms depending on both the agent and the patient. Chronic gastritis, or more accurately, chronic atrophic gastritis, involves chronic inflammation of the gastric mucosa that eventually leads to loss of cells, atrophy, and mucosal thinning. The most important and concerning feature of chronic atrophic gastritis is metaplasia. Metaplasia in chronic atrophic gastritis involves replacement of the normal gastric epithelium with intestinal epithelium, the hallmark of which is massive goblet cell accumulation. Gastric metaplasia is the precursor to gastric dysplasia, which is not good. Chronic atrophic gastritis comes in two broad flavors: environmental and autoimmune. Overall, environmental chronic atrophic gastritis is much more common, and as you could guess from the name, involves environmental causes. I'll give you two guesses as to the most common cause of environmental chronic atrophic gastritis, although it really should only take you one. That's right, herpes! Fine, alright, I'll stop with that joke. H. pylori infection is also the most common cause of chronic atrophic gastritis. Other possible causes include high salt diets, smoking, alcohol, and bile reflux. Symptoms of chronic atrophic gastritis are pretty nonspecific and include epigastric pain, early satiety, and dyspepsia, among others. Ooh, early satiety. That's the first time we've heard that one. And Terry from our clinical case had that too. I wonder if we're onto something here. Environmental chronic atrophic gastritis may be patchy throughout the stomach, although involvement of the antrum is the most common location. Definitive diagnosis is made via biopsy of the stomach during EGD. Multiple, separate biopsies should be sent to help determine the location most involved, which can help differentiate various patterns of inflammation, which may help identify the specific etiology, and thus pick the best course of treatment. Well, in our clinical case, Terry hasn't had an EGD done. But since this is the second time that an EGD has come up, I'll bet we're going to want to do one on our patient. It might even be the answer to the second question. Now let's switch gears over to autoimmune chronic atrophic gastritis. Autoimmune gastritis, which can lead to the so called pernicious anemia, is caused by T cell destruction and development of autoantibodies against parietal cells and intrinsic factor. It's most commonly seen in young women and is associated with other autoimmune diseases. Since parietal cells and intrinsic factor are concentrated in the body and fundus regions of the stomach, it's no surprise that the body and fundus are more commonly affected by autoimmune gastritis when evaluated by EGD and biopsy. Patients often complain of the same epigastric pain, early satiety, and dyspeptic symptoms as seen with environmental chronic atrophic gastritis. The major difference between autoimmune and environmental gastritis is that the loss of parietal cells in autoimmune gastritis leads to achlorhydria, meaning low stomach acid, which has multiple downstream effects. First, the drop in acid causes reflective gastrin hyperstimulation and even hyperplasia of G cells in the antrum. Low acid also disrupts the absorption of iron, which requires an acidic environment, leading to iron deficiency anemia. This occurs well before the infamous megaloblastic anemia has time to develop, in this case called pernicious anemia. Pernicious anemia is due to intrinsic factor destruction and therefore decreased B12 absorption. However, remember that most people have good solid stores of B12, which can last for years. Thus, B12 deficiency in these cases takes a long time to develop. So, if you're asked which type of anemia is more likely in the case of autoimmune gastritis, go with iron deficiency anemia. And well, heck, that sounds just like Terry from our clinical case. But he's a guy, and this autoimmune one was more common in women. And, well, we haven't really heard anything about Terry's weight loss, which really seemed to be worrying him. Like he just couldn't eat enough before he got full. So, I don't think this quite fits. I wonder if he initially had some environmental chronic atrophic gastritis going on, but then it got worse. Remember that we said the metaplasia could become dysplasia? We'll get to that in just a little bit. Treatment of chronic atrophic gastritis is pretty nonspecific, with the mainstays being H. pylori eradication and anti-acid therapy with H2 blockers or PPI therapy. We go over the details of this treatment in our peptic ulcer disease sketch. So if you haven't had the chance to check that out, we definitely recommend watching that one. Chronic atrophic gastritis may be annoying, but its major importance is its association with gastric cancer. Okay, back to our clinical case. Remember how we said Terry's chronic atrophic gastritis could have gotten worse? What if it's the C word? No, I don't mean crabs. I mean cancer. So much talk of STDs, guys. First herpes and now crabs. What's going on? I worry about you guys. Environmental chronic atrophic gastritis multiplies a patient's chance of gastric cancer by 10 to 15 fold. Autoimmune gastritis is also associated with an increased risk of cancer, but not nearly as much as the environmental type. Gastric adenocarcinoma accounts for 90% of gastric malignancies and comes in both intestinal, exophytic tumor, and diffuse, infiltrative forms. The major risk factor for gastric cancer, as we said, is chronic atrophic gastritis, and more specifically, the development of metaplasia that can progress to dysplasia. Additional risk factors include salted foods, especially foods preserved with salt, foods containing N-nitroso compounds such as cured meats, smoking, obesity, gastric polyps, Epstein-Barr virus, and, as with all cancers, it's been shown to have a familial predisposition and is associated with some syndromic mutations. But we aren't going to get into the details of those here. Well, our clinical case patient Terry sure has some of these risk factors. He's a smoker, and he eats all of those salty and cured meats just packed with N-nitroso compounds. Again with the nausea. Gastric cancer is not a good one. In fact, half of cases are unresectable at presentation due to its insidious growth and vague, nonspecific symptoms, which include vague epigastric pain, early satiety, nausea, dysphagia, and weight loss, which is usually from nausea and decreased caloric intake from the nausea and early satiety, not metabolic activity of the tumor. And yep, again, in our clinical case, Terry's got these with his epigastric pain, early satiety, and his weight loss. And remember his iron deficiency anemia? Patients may also have chronic upper GI bleeding, which may be very low volume, leading to iron deficiency anemia or a positive fecal occult blood test, or higher volume leading to melena. Well, this stinks. It sounds like this fits Terry's case to a T. Well, I think we have our answer to the first part of the clinical case. Patients with more advanced disease or metastasis may present with more specific signs and symptoms. Ascites, which may develop from peritoneal seeding of gastric cancer, is a very poor prognostic sign. Drop metastases to the ovaries may result in an enlarged cancer-containing ovary, also known as a Krukenberg tumor. Left supraclavicular lymphadenopathy, also called Virchow's node, or periumbilical lymphadenopathy, also called Sister Mary Joseph node, may also be indicators of carcinomatous involvement of the lymphatic system and are highly correlated with metastatic disease. As a side note, while often discussed in the same context as gastric cancer, Krukenberg tumors, Virchow's nodes, and Sister Mary Joseph's nodes may be associated with several types of advanced cancers. Diagnosis of gastric cancer requires biopsy with EGD. Just as I thought earlier, Terry is going to need one of these EGDs. He'll also need biopsy in order to confirm his likely gastric cancer diagnosis. Let's finish talking about gastric cancer and what Terry can expect. In contrast to benign appearing ulcers, gastric adenocarcinoma may have an irregular appearance, there may be an exophytic mass like this cauliflower here, or there may be irregular ulcerations or signs of bleeding. If you see a bunch of red stuff like this hot sauce on your EGD, you'd better take some biopsies as well as treat the potential bleeding source. However, one of the most important things for patients is to identify gastric cancer when it's early. This means taking multiple biopsies of any ulcers that are seen to rule out the presence of cancer. This also means that ulcers should be followed regularly to assess for healing. And if they aren't healing, more biopsies are needed and possibly even resection. The reason this is so important is because when caught early, patients have a much better survival rate. Finally, in patients with GI complaints without an obvious source seen on EGD, it's especially important to take multiple, deep biopsies, as diffuse gastric cancer can sometimes hide in the submucosa with no visible surface or mucosal changes, just like these intestine bits on the bottom of the bowl that can't be seen from the top. This is particularly important and true for the 5% of patients with diffuse gastric adenocarcinoma, which presents with the pathognomonic linitis plastica at diagnosis, also called leather bottle stomach. Staging also involves the usual imaging modalities: CT of the chest, abdomen, and pelvis, and endoscopic ultrasound, or EUS, in some cases. EUS is more invasive than CT, but it's also more accurate. PET-CT is not used as frequently in gastric cancer and may not supply much in the way of additional information. An important factoid for you: gastric adenocarcinoma, with its focus within 2 centimeters of the GE junction, are staged and treated as esophageal carcinomas. Gastric cancer is special, however, in that many patients undergo diagnostic laparoscopy for the most accurate staging. It's also called a staging laparoscopy. Go figure. This is because small metastases can be missed by CT and EUS, but may be picked up by inspecting the abdomen directly. Visually inspecting the abdomen, taking biopsies of any suspicious masses, and collecting intra-abdominal fluid for cytology all increases the detection of peritoneal seeding or metastasis. And speaking of metastatic disease, approximately 50% of gastric cancers are considered unresectable at time of diagnosis due to peritoneal seeding, invasion of surrounding structures, or distant metastasis, which automatically makes them stage 4. Some sources state that unresectability at time of diagnosis is as high as 90%. For patients with metastatic disease, and therefore stage 4 disease, surgery is contraindicated. For stage 1 through 3 disease, surgery has potential to be curative. For tumors of T stage T2 and above, neoadjuvant chemotherapy is recommended and, in rare cases, may turn an unresectable case into a surgically curable case. When talking about resection of gastric cancer, location is everything. For tumors of the proximal third of the stomach, total gastrectomy with Roux-en-Y reconstruction is preferred. It's also performed in most cases of diffuse gastric adenocarcinoma due to the diffuse growth pattern and high rate of positive surgical margins when partial resection is performed. It's important to note that a vast majority of diffuse type gastric carcinomas are unresectable at the time of diagnosis. While total gastrectomy for all gastric cancers used to be standard, tumors of the distal 2/3 of the stomach these days may be removed with partial gastrectomy and either Billroth 1, gastroduodenal, or Roux-en-Y, gastrojejunal reconstruction. We're not going to get into the surgical details here. In both cases, operations are typically performed open and involve extensive lymphadenectomy. In Japan and other Asian countries where gastric cancer is 20 times more prevalent — did you hear me? I said 20 times. What? In these countries, they perform a D2, or extended lymphadenectomy. While it removes more lymph nodes, it has an increased morbidity due to the extensive nature of the operation. In the US, most cases are performed using a standard D1 lymphadenectomy. Again, the details of these surgeries are beyond an internal medicine course. While adenocarcinoma takes the cake for the most common gastric malignancy, there are others, namely lymphomas. We're going to finish up this sketch with a short discussion of 2 types of gastric lymphomas. While you may hear it as maltoma, malt-associated lymphoma, pseudolymphoma, or some other clever combination oma while on the wards, extranodal marginal zone lymphoma is a primary lymphoma arising in the lymphoid tissues of the intestines, including the stomach. Maltomas develop in the setting of chronic inflammation, where prolonged accumulation and activation of marginal zone B cells eventually results in their transformation into lymphoma. Not surprisingly, chronic atrophic gastritis, especially of the H. pylori variety, is the main risk factor for maltoma. It usually occurs in patients around 60 and may present with abdominal pain, weight loss, GERD, or upper GI bleeding. As with other gastric cancers, diagnosis is with EGD and biopsy of tissue, which is used to perform histologic examination as well as flow cytometry and genetic analysis. Maltomas are, interestingly, curable with antibiotics. Eradication of H. pylori is curative in many cases, with another EGD and biopsy post treatment to confirm regression and eradication. If H. pylori eradication doesn't work, however, the treatment of choice is radiation. Surgery is typically reserved for complications of disease, such as gastric outlet obstruction, perforation, or GI bleeding. Another primary lymphoma is gastric diffuse large B cell lymphoma. While diffuse large B cell lymphoma is the most common type of lymphoma, The stomach is the most common site of extranodal primary lymphomas. Again, H. pylori is the usual culprit, as well as autoimmune diseases like SLE or Sjogren's syndrome, immunosuppression, celiac disease, and inflammatory bowel disease. EBV is linked to patients with immunocompromisation. Along with the usual gastric complaints of epigastric pain, weight loss, and GERD, patients may also have constitutional symptoms such as fever and night sweats. Diagnosis is made with biopsy on EGD. Treatment is with chemotherapy and radiation, with surgery again being limited to complications or in very early and limited cases of stage 1 disease. That's about it for our discussion on gastropathy, gastritis, and gastric cancer. Let's summarize. Gastropathy is damage, destruction, and erosion of gastric mucosa due to non inflammatory causes. It may be acute or chronic. Acute gastropathy typically presents with epigastric pain, with or without nausea and emesis. Acute gastropathy may be erosive, which may cause bleeding, which can present as upper GI bleeding with melena or even hematochezia. The causes of acute erosive gastropathy include NSAIDs, alcohol, iron supplements, chemotherapy, and cocaine. Stress gastritis is a gastropathy where ulcers may develop in patients who are critically ill, including mechanically ventilated patients, and patients with major trauma, sepsis, shock, or other serious illness. This is due to increased bile reflux, impairment of production of the protective mucus layer, and hypersecretion of acid. Ulcers in major burn patients are called curling ulcers, and ulcers in major head trauma are called Cushing's ulcers. Patients at risk for stress ulcerations are given prophylactic dose PPI or H2 blockers. Chronic gastropathy is the reaction of the mucosa to chronic exposure of an irritant. Again, these are non inflammatory irritants. The result is hyperplasia, edema, and smooth muscle proliferation. Causes include NSAIDs, bile reflux, particularly after GI surgery, abdominal radiation, mesenteric ischemia, and alcohol. Diagnosis of both acute and chronic gastropathy is made with EGD and biopsy. Treatment involves removal of the offending agent and PPI or H2 blocker therapy. Inflammatory substances result in gastritis. Again, this can be either acute or chronic. Acute gastritis is most commonly caused by H. pylori, but may be caused by other infectious agents as well. Acute gastritis presents with epigastric pain and nausea, with or without emesis. Chronic gastritis results from chronic inflammation, resulting in atrophy and mucosal thinning, and so is called chronic atrophic gastritis. Metaplasia may also result with massive goblet cell accumulation, which may then become dysplasia. Chronic atrophic gastritis may be either environmental or autoimmune. Environmental chronic atrophic gastritis is most commonly caused by H. pylori. It presents with epigastric pain, early satiety, dyspepsia, and other nonspecific symptoms. Environmental chronic atrophic gastritis most commonly affects the antrum. Diagnosis is made with EGD and biopsy, particularly of multiple locations. Autoimmune chronic atrophic gastritis is caused by T cell and antibody mediated destruction of parietal cells and intrinsic factor. It's more common in young women and is associated with other autoimmune diseases. Diagnosis is with EGD and biopsy. Autoimmune gastritis more commonly affects the body and fundus. Symptoms are similar to environmental chronic atrophic gastritis. That is, epigastric pain, early satiety, and GERD symptoms. Autoimmune gastritis may result in achlorhydria, which reduces iron absorption, leading to iron deficiency anemia. Decreased B12 absorption from achlorhydria and intrinsic factor destruction can result in megaloblastic anemia over time. Treatment of chronic atrophic gastritis is with H. pylori eradication with antibiotics and acid suppression with PPI and H2 blockers. Environmental chronic atrophic gastritis markedly increases risk of gastric cancer. Autoimmune chronic atrophic gastritis also increases the risk, but not as much. Gastric adenocarcinoma may be either intestinal type or diffuse type. Other risk factors include salted foods, especially foods preserved with salt, foods containing N-nitroso compounds such as cured meats, smoking, obesity, gastric polyps, Epstein-Barr virus, and familial predisposition. Patients present with epigastric pain, dysphagia, early satiety, weight loss, and upper GI bleeding, including iron deficiency anemia, positive fecal occult blood tests, or even melena. Advanced gastric adenocarcinoma with peritoneal involvement may also result in ascites and or Krukenberg tumors. Virchow's node and Sister Mary Joseph's node, Left supraclavicular and periumbilical lymphadenopathy, respectively, may indicate advanced disease. Diagnosis is made with EGD and biopsy. Linitis plastica, or leather bottle stomach, is a finding from diffuse gastric adenocarcinoma where the stomach becomes thickened and hard and physiologically fails to function properly. Diagnostic laparoscopy may be performed for staging with visual inspection and peritoneal fluid sampling and biopsy. Staging is performed with CT chest, abdomen, and pelvis, and endoscopic ultrasound. Approximately 50% of patients are unresectable at diagnosis due to metastasis. For patients with T2 disease and above, neoadjuvant chemotherapy is recommended. For resectable cancer, surgery is performed. For proximal lesions or diffuse cancer, total gastrectomy with Roux-en-Y reconstruction is necessary. For distal lesions, a partial gastrectomy may be performed with either a Bill-Roth 1 reconstruction or Roux-en-Y reconstruction. Lymphadenectomy is performed in all cases. Another type of gastric cancer is gastric maltoma, which is more appropriately called extranodal marginal zone lymphoma. Chronic gastritis is again the main risk factor, particularly due to H. pylori. Patients present with epigastric pain, weight loss, GERD, and upper GI bleeding. Diagnosis is made with EGD and biopsy. Treatment is with antibiotics, which is usually successful. If it's not successful, radiation can be pursued. Another type of gastric cancer is diffuse large B cell lymphoma. H. pylori is the most common cause and is associated with autoimmune diseases. Diagnosis is with EGD and biopsy, treatment is with chemotherapy, or in very early stage 1 cases, surgery may be performed. Alright, well, I'm out of here. Despite all the vomiting, I could still totally go for some curly noodles.